Joseph Lorado from Leatherman Spine. Quick funny story. So Dr. Lieberman was talking about his patients using tablets and the granddaughter working with the grandmother on how to use it. We tried to implement that at Leatherman, and after 2 weeks, all of our iPads walked out the door. So a little bit harder to do that over in Louisville. The study that I want to talk to you guys about today is the role of pelvic parameters, specifically pelvic tilt, on how we instrument S2AI screws. These are my disclosures, none of which are relevant to this talk. I don't need to tell everyone here that S2AI screws provide very rigid fixation across the lumbosacral junction, and that'll help us to achieve fusion there. We just published our technique on the freehand placement of these screws in JBJS in February of this year. And when we're thinking about freehand placement of these without fluoroscopic guidance, we really need to know how our hand trajectory is going to move to make these screws be able to be placed safely. So this is some background information. There's a cadaver model that was done back in 2015 that showed the average horizontal angle, and the horizontal angle is this angle that's subtended by these two lines here of 32 degrees, and the average sagittal angle, which is subtended by this line of 17 degrees. And then in our radiographic follow-up studies have showed some similar things. So our objective was really to assess the relationship between pelvic parameters and S2AI screw trajectory. We always know that a lot of times when we're placing these screws, it's for a deformity situation. And like many talks have alluded to before, there's a lot of compensatory mechanisms: hip hyperextension, knee flexion, and pelvic retroversion. And what we want to know is, when you're retroverting the pelvis and you're moving these things, how does it alter how you're going to place these screws? So we analyzed the preoperative CT scans of 33 consecutive patients. We looked at their standing x-rays to get their pelvic parameters, and we looked at their CT scans to get their optimal S2AI trajectory. This is our cohort of patients, 33 patients. The average sagittal angle in our study was 27. The average horizontal angle was 35, which is about equal to the previous studies. And this is the correlation that we looked at. We tried to correlate pelvic tilt, sacral slope, and pelvic incidence to these trajectories. And what we found was that there was no statistically significant correlation with any of them except pelvic tilt. And what we showed was that there was a moderate correlation with pelvic tilt, that as pelvic tilt got higher, as patients were retroverting their pelvis, the sagittal inclination got less. And this slide, I think, really shows this pretty well. Patients that had a high pelvic tilt, you can look on this group of images, that are retroverting their pelvis, their sagittal inclination of the screw was a lot shallower. It wasn't pointed down towards the feet as much. In terms of the patients that had less pelvic tilt, less retroversion, you're pointing your screw more down distally. And again, this becomes important because one of the worst complications you can have is if your screw breaches out in the sciatic foramen. So this is something that we need to think about if we want to continue to place these screws safely and efficiently in these spinal deformity patients. So obviously a limited sample size of 33 patients, but I think in conclusion we can say that patients that have increased pelvic tilt, increased retroversion, we want to think about not dropping your hand as much when we're placing these screws freehand. Thanks so much.